All right. Great. Welcome. We are excited to move into our panel on addressing HIV and substance use from a community perspective. And PACHA has not paid as much attention, I think, to this issue as we think we need to. And we are excited to move into this conversation today. Daryl and I are thrilled to be joined by three panelists to have this important conversation with us. We have Cindy Clay, who's the Executive Director of HIPS with us. We have Lyle Cooper, who is the Associate Professor at Meharry Medical College with us. And then Tony Young, who is the Founder and Executive Director of the Community Education Group. What we thought we would do is ask each of our panelists to start out with a little bit about them, their organization, what they do, and what are sort of some of their thoughts around priorities in their work. And eventually this will all lead up to conversations around, for PACHA, what we need to be thinking about in terms of our role as an advisory group to the federal government and what we should be prioritizing in terms of this work in this space and how we can actually be helpful. That's sort of where we will end up with. So who wants to start?
Yeah, sure. I'd be happy to start. Hi, everyone. I'm really excited to be here. My name is Cindy Clay. I use she, her pronouns. I'm the Executive Director of HIPS, which now stands for Honoring Individual Power and Strength. Formerly helping individual prostitutes survive. We're very excited to finally get rid of that acronym. For the past 30 years, HIPS has been working here in the Washington, D.C. community to improve the health, wellness, and rights of folks engaged in street economies here in the district, primarily people who engage in sex work and people who use drugs in the Washington, D.C. area. And we do that from a peer-led and lived experience model. Nearly 65% of our staff are former participants of the agency. 95 have lived experience in our issues. And I'm just super excited to talk about, I think, both our experience and successes around HIV prevention, what we're struggling with now, and what our hopes for the future are.
Perfect. Thank you so much. My name is Tony Young, usually Tony Young, but I'm going to leave that alone for today. But I am the founder and executive director of Community Education Group. Many people know of our work that we actually did here in the District of Columbia, where we created a program called the CHAMPS Training Program, where we worked with individuals who were returning citizens, formerly incarcerated folk, to do HIV, Hep C, and linkage to care efforts. Over the last decade, we have moved our work and actually done some project replication and model replication in West Virginia, but also throughout the Appalachia region and around the 423 counties of Appalachia. I'm super proud of the work that we've done there because many people said, you know, why would you go there of all the places on the planet? And I think some of the slides that you saw earlier about the outbreak in West Virginia, actually, can I get my slide? And I'll do my slide now and we'll talk about it more later. But I think that one of the things that people don't understand is that there's a unique culture of the 423 counties of Appalachia. I think we heard earlier about many of the challenges that are going on in Native American communities throughout the United States, but many of the similar challenges are being faced throughout the hollers and communities and towns that are a part of rural America. I'll go ahead with the slide. There's an Appalachian syndemic that's growing. And what I like to think of it as is that there's a train, and I think of it as a train that's roaring through Appalachia, with the engine of that train originally being kind of injection drug use, and then it moved to poly drug use. We've then got hepatitis C, hepatitis B, hepatitis A, workforce development challenges, economic and educational development challenges. And then on top of that, what you have to do is think about each one of those cars being laden with the heavy impact of environmentally, socially, and economically of coal, and the caboose of that train being HIV. Many people thought when I said, you know, what we have to be prepared for is an HIV outbreak in West Virginia, they thought I was bananas. There are companies that thought I was bananas. There's folks at NIH that thought I was bananas. When I talk to them about Hep C, they're like, you're crazy. No one's going to give you that kind of money to address it. But if you really kind of look back at the data, West Virginia and Kentucky have vacillated between 1, 2, or 3 in hepatitis C rates in this country. But we don't think about that. We think about big cities. We think about urban and opportunities, but not necessarily rural. So when I walk into a room today and I'm talking about Appalachia, I'm typically not the face that they think that they're going to see. To talk about Appalachia, they are usually a little shocked, taken aback. I had the good fortune, I believe it was Monday, to have a conversation with Gail Manchin, who is the chair of the Appalachia Regional Commission, where we talked about all of these issues in a live interview. And I know one of the things you're going to ask us to do is to give you a strong recommendation. And the first recommendation I'm going to ask for PACHA is A, to convene one of your meetings in Appalachia, particularly in West Virginia, where I think is the center. The second thing I'm going to ask you to do is to do that in partnership with the Appalachia Regional Commission. I think it is there to serve the people of Appalachia. It has substance use disorder, public health, education, and workforce development as its priorities, which are actually in alignment with yours. I think I'll stop there and talk more about the work that we do. But again, I'd like to thank you for the invitation to talk about the people of the Appalachia region and the work that we're doing to support them. Oh, yeah, you got your own. Well.
I'm Lyle Cooper. I'm with Meharry Medical College. Should we don't have it on? Oh, they gave me a faulty one.
And there you have it.
Try this again. Is that better? Great. So Lyle Cooper, I'm with Meharry Medical College. We're the second oldest HBCU medical school in the country, and we're also the largest historically Black academic medical center in the country. And I'm a part of the Department of Family and Community Medicine. I also partner got some fans. We partner really closely with our internal medicine department, who does a lot of the HIV infectious disease care in partnership with some of the things that we do, and also with the Department of Psychiatry, who provides substance use disorder treatment for the folks that we work with. I've been there since 2015, and in that time, we've really tried to build up first our outreach efforts to do harm reduction, sort of intervention in the communities where people reside around substance use disorder and also infectious disease prevention. And then later on, we've started a clinic that's a low threshold buprenorphine clinic that's sort of a home base for a lot of the outreach efforts that we do. It's also located very close to the other two clinics that I talked about, so we kind of have the ability to loop all of those services together. And then in the past few years, we've really been working to integrate the work that all three of our clinics do by sharing some staff, by going after grants together, so that we're all sort of focused on the same mission. I should say too, I myself am a person who came to this work through lived experience, and most all of the people that we hire are also folks with lived experience from the top to the bottom, and typically folks that reflect the populations that we serve, which we think is really a critical element to what we do. We do a lot of things in addition to our service. We're also at an academic medical center, so we do a lot of training with new physicians to try and train them around substance use disorder and infectious disease. We train them on PrEP, on HIV testing and counseling. We also work with psychiatry in that respect to try and kind of bring some of the things that they do more into a harm reduction lens, because a lot of folks that go into substance use disorder treatment don't necessarily see their work with substance users as involving harm reduction. It's more about a recovery mindset, which is important, but it's not the only thing. In fact, we always say our goal with our patients is to just get them to take one positive step that they are interested in taking. And we're going to help them do that in any way that we can. So I mentioned at the outset, I'm at Meharry. Meharry is located in Tennessee. Tennessee's always been kind of a difficult place to provide services for a range of reasons, but in the past few years, I think it's become even much more difficult in the past few months, honestly. I mean, we've had things going on where we've passed bills that make it illegal to be unhoused in public. So people are getting arrested and moved all around the state as a result of that. We've just passed a bill that outlaws drag shows, basically, which a lot of folks are really concerned about. In that, I mean, it's one thing to think about the show. It's another thing just to think about how you present yourself in public. And so that's caused a lot of stress and strain with the folks that we work with. We're also in the process of trying to allow county clerks to deny marriage licenses based on their own sort of religious beliefs. And then finally, I think the thing that people are most aware of right now is our returning of the CDC funds, which we're not totally sure is going to happen, but it kind of seems like that's the direction that we're headed in. I say all that to say, I think it's created an environment now that on the one hand was already resource poor because we didn't accept Medicaid expansion. We're actually a state that asked for a waiver to allow them to put a cap on the amount of money that they spend on Medicaid, which has caused many people to lose care. Even folks that work for us have been losing their care for HIV and for gender affirming care. And I think on top of the loss of resources, one of the things that's really been troublesome is just the message that all of those policies send in general to the folks that we generally focus on. I mean, I left this part out, but part of the funding that's going to be drawn back is EHE funding that goes to Memphis, Shelby County, which is a majority African-American city, and one that has also seen some of the highest rates of HIV pretty much for years and years and years. And so the removal of those fundings, that funding, I think is particularly difficult. It seems like we're just sending a message to the people that are generally our populations of focus, that the state has no concern for them. And further, that it's kind of a scary place for people to be, which we can talk about as we go throughout this presentation, because I have lots of examples of things that we're seeing happen already just in the months since some of these things have been taking place. So that's kind of a downer. We have some ideas on how to address some of these things, but some are kind of out of our reach. So I'm interested to have this conversation and see if some more things can come out of it.
Thank you, panelists, for the introduction. Wow, where do I begin? I'm gonna, because Marlene said I could, use a little bit of my time to introduce three themes, and I tried to tie them to what you were doing in your introduction. These come from the presentations that we heard just before the panel, but also in terms of my nearly 35 years in HIV prevention and community work. Medicalizing people and the variables that we are discussing. Two, starting where people or clients are, as we saw, is a critical, and which also relates to biomedical and interventionist bias, implicit or explicit. And then three, lag time. I think lag time, meaning the time from when communities know there's a problem to when stuff happens. Let me say something about those, and then I'll try to be very quiet and listen and ask you to think about these questions, but think about them in the context of the work you're doing. Medicalizing approaches. When we talk, and we heard language, putting people first, a people first language as opposed to a disease first. Making things like ACEs a medical or biomedical thing that you can fix. And it defies some rational logic, because a lot of the stuff we're talking about are oriented in cultural, historical, and emotional beginnings, not biomedical. And when you talk about people's reactions and thoughts to substance use, prostitution, sex trade work, whatever we want to call it, drag shows, those are emotional. Those are cultural. Those are not biomedical. So how do we address situations that are not or defy, and I think this is why it's challenging for many of us, because they are not easily extracted like a virus. Number two, starting where people are, thinking about the language, and maybe this adds to it. I try to avoid using a phrase, starting where people are, because you don't add the rest of the sentence. You can only start where people are, where you're capable of being. And I think everything that we've talked about today in terms of individual bias or provider bias is about where I am in relationship to, and let me talk to the scientists in the room briefly. You would never do an experiment without considering the ambient conditions in the room, the light, the temperature, the humidity. But somehow when we talk about starting where people are, we forget that we're in the relationship with them, and therefore we're not an element that impacts that variable. We do. And you do not start where people are unless you're capable of being there. Number 3, lag time. When we talk about things like harm reduction and the right of housing, how many people have heard about that for the past 40 years? There's nothing new here, but now it's an epiphany that it's a critical thing. And I believe one of the things that we miss is that communities have been saying this for 40 years, have not been heard. And now we want to say because a particular structure has validated it for you, you may now have a voice at the table. And I think Tony Young had a comment about that with Cole and being unheard. Cindy, you clearly had a comment about the communities, and I saw your face light up when I said what I said. And Lyle, if I may call you Lyle, Dr. Cooper, I think you were talking about some of these. So those are my contributions to, and no disrespect to any of the presenters, but when we're talking about community and the rubber hits the pavement, I have learned and feel that I've earned my senior status by if I don't speak a truth, then we keep recreating a lie.
So, I mean, everybody in here who knows me, so you should have known I was going to grab it. Here's the thing. There's a couple of things. And I think we have to tell ourselves another set of truths, right? I think that, yeah, maybe people in certain places have been talking about this and doing this for 40 years and walking this walk. I mean, I've been doing it 30 years. We're getting ready to celebrate our 30-year anniversary too, right? But the reality is that some folks in these hollers and other places in rural America have not been having these conversations for 40 years. You know, until this opioid crisis knocked them upside the head, they weren't trying to have any kind of these conversations at all. The other thing is that people are sick and tired of it. And so, you know, we saw a whole bunch, they're sick and tired of the opioid crisis. They're sick and tired of you wanting to come rescue the folks. They're sick and tired of you wanting to medicalize them. They're sick and tired of it. They're sick and tired. They're done. They don't care. Okay, if you're going to overdose and use drugs, then go ahead and die then. And I can tell you that I've had a state legislator say that to me to my face. We don't need to put programs in place. People need to stop using drugs. What do you want from me? Well, I'd like a comprehensive program. No. Well, these are your families. These are your friends. These are your neighbors. These are your colleagues who are, okay, then they need to stop using drugs. We need to stop paying for it. If we can keep paying for treatment, then that's what we're going to keep seeing, and that's what we're going to keep getting. In the state of West Virginia, and I bring this up many, many times in many, many rooms, there are 9 methadone programs in the state of West Virginia. You saw the data on the opioid crisis, the overdose death rate in West Virginia earlier today. Keep that, wrap your brain around that. 9 methadone facilities in the entire state. 7 of those 9 are owned by one company. The other 2 are owned by another company. For the past 5 years, we have been trying to move legislation which will eliminate the moratorium, because there's a moratorium on opening a new one. You cannot legally do it. We first got told, no way. We got good traction last year, but we got stuck behind the critical race theory in schools bill, and they timed out the legislative clock. So we thought, well, you know what? We're going to rush in there this year, and girl, we're going to get them. Well, not so much. They were very clear with us. There's no room for that. There's no stomach for it. Don't try to bring that bill this year. It got out of committee, and that was it. And it was dead. It was dead on, would dead on arrival be the approach? He used to be the policy director. And so we look at that, and then you think about the next phase of that. Okay, so we have to then think about that psychologically. So what is it that community thinks and what community believes? I mean, provider community, public health community, within that region, they say, well, methadone is just another drug. It's not seen as a treatment paradigm, right? So they don't want it. They don't want to have it. And so those 7 and those 9, that total of 9 will be the only ones. The other piece that I believe, and I say this often, where we have missed the big sweet spot is with MAT providers. Once an MAT provider in this country typically gets their license, that's it. They never really re-engage with the state. They only have to do is re-up their license, make sure that they meet all of their deliverables on their terms. But we don't engage them really in the HIV space or in the Hep C space. Where's the National MAT Provider Conference? You don't see it. Do we train them to do social networking theory? Most states actually have a mandatory HIV Hep C screening for these providers. But many of them, particularly in the Appalachia region, say, we're going to let them opt out because we're not going to press them to take a HIV or a Hep C test. But then that means we're not re-engaging or relinking them to care or getting them cured or getting them to next to zero, right? So we're missing out on this huge population of people that we could be educating, treating, linking to care, and then doing the next piece of work, which is getting to a place of employment. Because what we could also be doing in that same social network is training them to do peer navigation for like-minded folk. Because that's the other thing. We've got to get the folks that know the folks to do this work. Not having someone think that they're going to go to a big hospital system 40 minutes away or an hour away. We've got to train the folks in those hollers to do that work. So that's one of the big challenges that I see before us is figuring out not who our partners were 40 years ago, but who our partners are today. And our partner is a different partner today. And our partner may not look like we look. And our partner may be a harder sell. And we may not be able to get it all. We may be able to get, okay, all you're going to do is test. Or all you're going to do is relink to care. And okay, I can't have the conversation about this, but I can have it about that. And I think sometimes we go into it in an all or nothing mentality. And the last piece that I'll say on this is that the other thing, again, about partnership is that we really have to be looking right at this moment. What's going on with the opioid abatement settlement dollars in this country right now? That's a big pot of money that we have, has gone to attorney general's offices, is not coming into local public health departments, is going to go right straight to the counties. It might go to a health department in some states. It might go over here in some other states. But we're talking billions of dollars that is going to impact our system. And if we don't get those dollars back to those communities most impacted by substance use disorder, HIV, and Hep C, the ones that actually are most impacted, families die. I like to say that the opioid abatement money, the opioid settlement money is about community, it's about family, and it's about America. And this is what we've really got to remember, is that those dollars can disappear overnight into the ether. Gone. If we don't do something now, this isn't 6 months from now, this is now.
Thanks. It's like, I appreciate that. I appreciate that. Thank you for the guiding questions. Thank you for that. I think some things that I was really struck with as we were talking today and as I was listening to the presentations beforehand, I think what we've been facing specifically in DC, and we have obviously a very, very different circumstance. DC is an incredibly progressive city. We have a health department that has literally been doing until recently some of the most innovative HIV prevention work that I have seen, across the country. And I think what we are beginning to see and what my concerns are beginning to be is that we are potentially seeing the dismantling of strong HIV-related programming within our health departments and within our cities. And my biggest concern about that is that we are, especially for people who use drugs, we are now relying on opioid settlement money. We now are relying on state opioid response grants, and that money is going through departments of behavioral health which have long-term experience working on treatment programs for folks. But my experience has not been that they don't have a lot of experience in prevention, education. They don't have a lot of experience in behavioral interventions this is my poker face. They don't have a lot of experience in behavioral interventions that help change behavior outside of abstinence. And they have little to no community input or engagement, unlike what we have built through 30 years of HIV community planning groups and Ryan White planning councils and that kind of thing. And so what I'm seeing is money being diverted, especially for people who use drugs, away from HIV and AIDS administrations into Department of Behavioral Health, which is fine and great, and we need that money. We definitely need to do something about overdoses. We definitely need to do something about accessibility to treatment because people are dying. But the way that process has really worked, and our folks who have been most on the ground and impactful in that, in HIV, in MPOX, in initial COVID response, has been the organizations that learned those steps through the HIV crisis, right? HIV organizations are a syndemic approach to addressing the public health needs and our social determinants and our health disparities. Like, the highly effective organizations have been doing that this whole time. Harm reduction organizations have been meeting people where they're at with that prepositional dangler for 30 years, right? And now suddenly it's everywhere and everyone's saying it, and that's great, but we deserve more than lip service. And we deserve for the organizations that have been doing this work to both be supported, but also we deserve our cut of the funding. And I think that's a big concern that we have. I mean, I was at the National Harm Reduction Conference this past fall, went to probably 5 different presentations on organizations that had low threshold buprenorphine programs, right, for active drug users, that they were harm reduction programs that were running these. And HIPS had one that was highly successful. We had 287 patients, 45% who had been banned from every other drug treatment program in the city. And we had an 85% retention rate after a year, right? Great program. Can I fund it? Absolutely not. Not a single one of the 5 programs that I went to presentations on at the National Harm Reduction Conference had sustainable funding for their programs, because medical billing was not going to be an option for us. And there was funding for the wraparound services, but there was absolutely zero funding for a prescriber. And prescribers are very expensive right now because they can get very, very good jobs at for-profit corporations running 1,000 people an hour through a treatment program. And that's not going to meet folks who are experiencing health disparities. And that's not going to get us to racial or socioeconomic equity in drug treatment access. And so those are the things that I think we as a society and we as a group really need to look at, think about, and make sure that we are not completely dismantling the folks we're not dismantling the systems that learned so much over the last 3 years about engaging, about working with people, and about getting people into medical systems that, quite frankly, were abusive or not designed to help them.
Yeah, I think it's a lot. I was just thinking about the comment about harm reduction, housing first, being around for a long time. And it is true that all of us probably in this room have been hearing about it. However, I think there's pockets of the country that just really have never acted on that. I mean, even in Nashville, which would be sort of the most sort of forward-thinking city, I would guess, in Tennessee, maybe. I don't want to take that away from anybody else there in Tennessee. We still can't get a housing first program, even though that was recommended to us through our housing needs assessment. What we find is when we do start something that's housing first, you may be able to get somebody into a house, but if they're found to continue to use, then they no longer have that space, which kind of defeats the whole purpose. So I guess the ideas are out there, but I don't know if they're always trickling down to every place that really needs to have those things happen. I think another thing that's been interesting about that, especially in terms of harm reduction, is it's sure. I mean, I've been engaged in the practice for 25 years. However, even at the federal level, it really wasn't a good idea for you to say anything about harm reduction in applications that you might write to federal organizations up until just a few years ago. And on top of that, we're just now, I mean, last year was a fantastic year for this, and that we finally did allow some of those funds to go to the purchase of harm reduction supplies, i.e. syringes and cookers and the things that you need in order to engage those populations. But we're still not where we need to be, even though, frustratingly enough, we're 30 years into having this conversation. I think that's one of the things that in terms of one of the things we talked about before the presentation, or what were some things that PACHA can do, or that we would like to see them involved in. I think that is a huge piece of moving forward, is how do you get those supplies funded? Because when you look at a state like where I come from, we don't have Medicaid expansion. We actually have a limited Medicaid provider. The idea that we're going to be able to make money from someplace else and bring that around to purchase those syringes is almost impossible to consider. And so if we were able to do those sorts of things, it has a whole number of sort of upstream and downstream impacts. I mean, first off, syringes save lives in terms of preventing infectious disease. But the other thing that we know is that as we do engage people with those programs, you've got whole populations of folks who really don't have a great deal of trust for medical establishment, don't have a lot of trust for providers just in general. And so the syringe is the way to start to create that relationship. And if you don't have that way to kind of continually engage patients with something that, I'm sorry for the use of patients, but it's the working in a hospital, it's hard to get rid of. But if you don't engage them over and over, you are never able to kind of help them move forward in a sort of continuum of needs that they may have. And you have to have the things that they actually want that day, right? I mean, it can't just be the things that we can offer, because they may not have that interest, they may not have that trust in us at this point. So that's one thing. I think another thing that's I notice in the medical education sphere is that we do work across multiple departments, but as you move from department to department, or from clinic that's hosted by a particular department to another clinic, they have wildly different views, and I have sort of different difficult abilities to work across the medical disciplines. So, like, just for example, to get our internal our clinic that treats HIV and hepatitis C, fantastic doc for people with HIV and hepatitis C. However, the idea of referring somebody over to our clinic for buprenorphine is something that they're not really interested in doing, because they see it as a trade-off of one drug for another. Tony was talking about methadone. We still think buprenorphine falls into that sort of category. So I think there's, and I guess psychiatry similarly, right? We do have a low threshold buprenorphine clinic. People can keep on coming regardless of what they do with their other drug use. Even if they're continuing to use opioids. I mean, our number one goal, I try and express this to the docs all the time, is, job one, let's keep people from overdosing. If they take another step, that's fantastic. If they don't, we saved a life, right? I mean, that's what we're really here for. But then in psychiatry, they have more of a focus on this recovery sort of mindset, and that's not something they're really willing to engage in. And so I think there's a lot of sort of cross-disciplinary training that needs to be done in order for us to really have the most impact. Because all of the things I just mentioned, right, a recovery mindset, it's important for people who want to stop using drugs, right? I certainly don't want to pitch that out. But at the same time, we need to have every space in between, from let me give you a syringe that's not going to give you hepatitis C or HIV, all the way to, okay, now you want to stop, let's do everything we can to help you stop. But right now, I think that's really patchy, and maybe even more patchy in certain regions of the country.
Thank you. So a couple of things. One, first, I wanted to say that I wanted to thank particularly the Centers for Disease Control. And why is that? Because many of you don't know is that CDC actually opened an office on rural health. We've been advocating, along with the National Rural Health Association, for over a year and a half for there to be an Office on Rural Health that would be the partner to what happens at HRSA's Office on Rural Health. And there was money put into the budget, and there's now a person there. And I think that that's one of the, what can we do? I think we invite them in. I think that rural health conversation is a different one. I think the other thing that we do is that we eliminate the rural health calculator, right? Because what happens is that rural counties who have to then go to the rural health calculator, see if my program can apply for the grant for my rural town is like, oh no, my office is across the street in the different zip code, so I can't qualify for this grant. There's got to be a better way to do this. And the other part of that rural health calculator piece is that if you look at Appalachia, Appalachia is comprised of 423 counties. West Virginia is the only state 100% in Appalachia with its 55 counties. 44% of those counties in Appalachia touch on more than one state. We have got to figure out a way which those organizations and institutions which serve multiple states and counties can apply for federal funds. Right now, most applications would have them limited to one state and not be able to move that money across state lines. Again, another reason why I think there needs to be a conversation with the Appalachia Regional Commission, because right now they're the only ones that are allowing many of these organizations to move across state lines. And I know that that's one of Ms. Manchin's priorities, is to really figure out how we allow these community-based organizations who are doing substance use work, workforce development work, who are doing educational attainment work in those 423 counties to move that across state lines. We, our community education group, is really trying to get language into every federal NOFO. We think that there should be language in there that specifies these 423 counties as unique in what they are and where they are and their health impact in the United States of America. The other thing, and we were talking about this in the car, kind of like in the car usually when you're going home after the party, but we did it before, but was about sustainability. And when you start writing your sustainability plan, or when you're doing your report and you're writing your sustainability goals, how are you going to sustain it? I don't think the federal government is our sustainability plan. I think that that's just our reality in 2023. Our sustainability plan can't be a 3-year, 5-year grant, which may go away. It can't be. It just doesn't work. And I think that what happens is that we get sold, come apply to the grant, come get this grant. But then you've gotten your legs under you, you're 3 years in, and then all of a sudden they go, well, you know, our priorities shifted and that money's not there anymore. Think of something new. But now you've got people, you've got staff, you're engaged. I think one of the things that, you know, that business program that I think Harold was talking about earlier and that others have been talking about, it's not quite the business response to AIDS, but it's close. We have got to figure out how we're going to engage the Amazons of the world, the Googles of the world, the folks that are in the manufacturing of those syringes, the folks that are manufacturing the naloxone, the folks that are manufacturing the packaging for naloxone. How we're going to get them to give us skin in the game to do the work that we need to do. And I think our federal partners can help bring them to the table for a conversation, to do some meet and greets of who the people are. I think we can do that, but I think it's unfair, honestly, for us to say to the federal government, you're our sustainability plan. Because I think it changes too quickly. We saw that with, I think, some previous administrations. So if we don't get our corporate partners to truly invest in these communities, to truly figure out how they're going to grow a workforce, right? Because it's not all about intellectual capital. We need people that are going to run the machines. We need people that are going to drive the trucks. We need all these people to be there, but we need them to, you know, we have to have some agreement on what is, I know somebody said don't get dirty, but what does sober mean? What does okay, what are those guidelines going to look like? We've got to have those conversations. Because it might be for one company, buprenorphine, not good. But for another company, okay. We've got to do that. That's our sustainability. Sorry, I get
Yeah, I want to just to jump off of what Lyle said. I said this many, many years ago, I think in one of the first conversations that SAMHSA had around needle exchange. And I was like, needles are condoms that people actually want to use. We should make that a t-shirt. No, I mean, but it literally, like, people are really, really want them. I'll tell you that as someone who has finally been able to run a needle exchange since 2007, when DC was actually allowed to invest our own local dollars. And I can't tell you the impact that that's had on our HIV rates here in DC. We've gone from here to here amongst injection drug users, like practically unheard of to have a new infection. I think we had one last year, even during the pandemic. Right? So they are so successful. And I can't say that we just need to find a way to allow us to buy them with the money that we get in order to do prevention services, because we can't do prevention services without syringes. It's like you're telling us how great we're doing as harm reduction organizations. Thank you, harm reduction organizations, but we're going to make you work with like 3 arms tied behind your back. Because you can't have literally the thing that people want to come into our programs for that literally prevents the transmission when people inject, right? I mean, just not only is it a great engagement tool, because it is a great engagement tool, how it is also like one of the most proven interventions for HIV prevention, like, that has ever lived. And so I like the fact that we're still having this conversation, the fact that we still can't buy the supplies that we need to, is really a problem. And, overdose prevention centers are HIV prevention centers. Overdose prevention centers are places where people can access vaccines and where they get education in a caring environment that is literally set up for them. And I think, like, especially overdose prevention centers are places where youth and young people who use drugs, who are less injection oriented potentially, but are using more of the pills. Our trans women of color in DC are definitely at risk for this. We've had a lot of overdoses in the past few months around folks who are buying fake pills or that kind of thing. Like, overdose prevention centers are going to engage those communities where we can link them to care. They're like gathering places where people want to feel safe and feel like they have a place. Taking medicines for HIV, taking medicines for opioid use disorder, those are behavioral interventions, right? And so the biomedical is important. We have biomedical strategies, but in order to access those biomedical strategies, you need to change your behavior. And in order to support people who haven't traditionally accessed biomedical strategies, that is a process of behavior change. That is a process that is really, really important. And HIV and harm reduction knows how to engage people in those behavior change, and we need to invest in those kinds of practices.
Yeah, for us, the last thing we were able to start was a syringe service program because of the expense associated with it that we couldn't get in other ways, which is kind of, the actual cost of it much cheaper than some of the other things that we were doing, but just the money is so earmarked. Another thing that I think is really critical is how we view the people who work in this workforce. I still see applications for grants. I still work with insurance providers that don't want to accept peer workers. So one of the things, and then two, this is an organizational problem, one that I think we all have to work on and advocate for too, is that even when those folks are hired, they're usually not hired at a living wage because their experience is not considered as important. But what I would say is that work, that ability to connect with the people that they encounter when they're doing this work is valuable beyond measure. When you do, going back to the idea of, and I totally agree with you, I don't think syringes are just for a means of engagement. I think they're an end in to themselves, but they are also a means to engagement. And when you have the ability to see somebody every day, every week, however often they come, and they have people that are there who actually have been in their shoes, who maybe are still in their shoes, right? That is, it just allows such an easier way to engage than making the benchmark for somebody who would work in this space, having some sort of professional degree that sometimes, honestly, can make it more difficult for the person who's engaging care to link with that person. So I think that's a really, really, I think that's something that we have to really focus on, is how do we make these folks more valuable. I think the efforts in terms of recovery support services has been a good step, but I think we still need to go farther in that area. Well,
Okay.
Okay. One of the challenges that we're currently having with recovery support services is that underneath the current guidelines, you must be abstinent from drugs in order to be a peer recovery support specialist. And one of the things that we always say is people in recovery are great peers to other people in recovery. They're not always, although they can be, great peers to people who are actively using drugs. And so one thing that would be extremely helpful is an opening up of those guidelines so that people don't either have to lie or not be able to access an application because they are a current drug user trying to educate other current drug users.
I didn't forget. I think that one of the recommendations I would make is twofold. One is getting to that point is that there needs to be a national standard, because right now it's state standards. Every state has a different approach for what a community health worker is, what a peer recovery coach is, what a this is, what a that is. But if you kind of go down the checklist, they're very similar things, if not the same thing. I mean, if you take the model out of Boston, it basically covers everything in every state, but you can't get coverage for everything in every state unless somebody writes a law that says, here is what a community health worker is. It is valid across all 50 states and in every county. It can't be overridden by state statute. I think we've got to get that, because the other piece of this is groups like I mentioned earlier, these MAT providers that are small, maybe seeing 20 to 50 patients, not kind of the larger ones, don't know that they can get reimbursed for these community health workers. Don't know that there are other ways for them to structure how their organizations run if they use these peer recovery models. Because they're so small in practice size, they say, well, I'm just going to get them in and get them out. I'm going to do the minimal behavioral health touch that I need to do. But if we help them understand and train them that they can use these other models, social networking, peer recovery coaching. But again, I think the bigger challenge is that there's not a statewide national model for what one is. If you go to, we're in 12 states. We had to build a model that would be applicable across 12 states, that would cover every touch point in every 12 of the states. Whereas when we did it in DC, we only had to deal with the DC rule. But now, if we want a national model, which we actually are getting ready to build, we have to make sure that it meets the element of every state across the United States.
Yeah, absolutely. I think, our experience has been we engage in a lot of workarounds. They're not really solutions broadly. There's solutions for us. One of the things we've done with the peer recovery work is to kind of redefine recovery for the other organizations that we work with. We say our and I didn't think of this was Dave Purchase, but the idea of one positive step. We say recovery is when you make that one positive step, right? If you're making that step, then you are in recovery, right? And the reason why we do that is not because we love recovery language, but it's because all of the services that people could generally access in our area are contingent on that idea, So it's not a larger solution, but it is sort of a way for us to make it happen within our communities. There was one piece of this that came up a minute ago around sustainability, and we talked about this on the way. Is should the federal government be the sustainability plan? No. Are they in states that don't have Medicaid expansion, that are squeezing sort of down on any sort of reimbursement you can get for a lot of the services that we provide? Yes, they are. Without that funding, I know we would not be able to do the things that we do. And two, I mean, I don't know that some of the, and without Medicaid expansion, one of the things that happens with us is there's a lot of thriving buprenorphine clinics in my area where the hospital actually works. But the folks that come to us are generally, I think we run at about 70-ish% of the folks that come to us are homeless. About 90% of those folks are uninsured. If they're working, they're usually working in jobs that aren't going to allow them insurance. And so, the idea that the difficulty of kind of changing a payer mix so that we could bring in some of those folks who are going into a nice fancy clinic, they can just pop into their car, pop out, not really have the fear that people are going to know where they're going versus coming to our hospital where they have to go up 3 flights of stairs, park across the street. And then when they get there, they may encounter a group of people that they don't typically encounter. It's just, I think the sustainability is such a tough thing when you don't have a publicly financed healthcare system, or even some fraction.
So we want to invite the council to ask your questions. So please raise, and our federal partners to participate. You can certainly put up your name cards to join in on the conversation. And as we're going to pass it over to Marlene in a second, you all, this is exactly what we hoped, is we could listen in on a conversation between the experts up here who come from, whether it's the urban, rural, academic settings, right, and help us sort of understand some of the issues. You're going to get the last word with us. And the last word is a plea for help around, as PACHA, an advisory committee to the federal government, realizing we don't advise states and other things. What is one area or thing you think we ought to be diving deeper into, or a recommendation we ought to be really focused on? So you'll get the last word on that piece. So Marlene.
Sure, I'll be brief. I just wanted to thank Lyle for lifting up the accountability, and something that I think as a council we probably need to watch for in terms of our federal partners have given lots of flexibilities to their grantees, but I do think that deeper dive into what is occurring actually as a result of those flexibilities were really unclear. I know there's been a lot of allowances, particularly even through housing, but I'm not sure I'm realizing that at the local level. So I appreciate you raising the point, and I do think that's something we should pay attention to. My last point is what Tony raised in terms of the opioid abatement dollar accountability and monitoring. I think we need to be doing. I'm a little clear about the way it's being handled in Texas, as an example, and I'm really fearful about what those dollars may turn into. It's being organized by the governor's office. It's being facilitated by leadership, certainly through all of the major counties around the state, but it's sheriff's offices. It's primarily law enforcement. And so what those dollars will ultimately turn into potentially could be things that are creating more harms in some of the communities that we're trying to serve. So I do think that's another issue to be mindful of. So I just appreciate you lifting up those two issues.
Thanks, Marlene. I think Harold's comment from yesterday, sort of around we can't treat every place as equal because the issues you're facing are very different. And we're going to have to come up with sort of different approaches that actually work. Kristen.
Thank you. I had actually wanted to make a comment in relation to the peer recovery support services. Dr. Cooper, I think you were the one who maybe mentioned that these people are oftentimes underpaid. And another thing working for SAMHSA that I have seen for sure is people can get hired as a peer recovery support service, a peer, but that's the ceiling because they don't have the educational background that maybe would be required differently. So I did want to just make a comment about what SAMHSA is doing in this regard. So for our key personnel requirements do not include an education requirement at all. So that's one piece. And then the other piece, and I wanted to read this, I presented on something yesterday, and this slide didn't make it into my final presentation, but I did want to read the language that we have added to our new grant programs under the key personnel piece, which is award recipients are encouraged to consider hiring people with lived experience with substance use disorder, co-occurring substance use and mental health conditions, recovery, and or people living with HIV in lieu of education as appropriate. And we've added that to the new grant programs. The reason for that is we cannot provide requirements for our organizations to not have an education requirement, but we can encourage. So we have done what we can. So I wanted to say, we've heard that and we have responded.
Thanks. Other questions from council members or our federal partners? Daryl's going to jump in.
So maybe a question, but I'll begin with a comment, and hopefully that triggers another or leads to another question. Be cautious of words, right? You talked a lot about the resistance. I mean, Tony Young, you specifically called resistance. We talk about the lack of money, but then you caveated it, Lyle, by saying, well, maybe it's not the lack of money, but it's about the barriers around the money. I really want to pick up on these themes that somehow and maybe this isn't true, do we sometimes set ourselves up because we frame the argument without incorporating the resistance that our pleas and plights are going up to, and we act as if it's a neutral playing field. And what are the dangers in doing that if, as you point out, we have to develop different partnerships?
I would love to. You know, I mean, I think that you've hit the nail on the proverbial head. I think that we have, and we still continue, to believe that the majority of, whether they're our political partners or even our political foes, you know, we may see them as a political foe, but they may be the keeper of the key, right? So I got to figure out how to get you part of what you want and part of what I want. You know, I don't, you know, it's like I try to, again, I mean, you look at me, do you think that, you know, people thought I'd be the one running around Kentucky going, hey, we really need some help. Come help. You know, no, nobody thought that. No one saw that one coming, including me, right? But in order to develop real partnership, I've got to figure out what do they want? What do they want? If it's a political person, what do they want and need for their constituency, right? What they want is jobs. What they want is economic opportunity, right? They want to stay there, and they want to stay elected. So here's the thing: what do I got to do? I got to figure out how to get jobs to those hollers. As I always say, I say it whether we're talking to ARC, talking to you today. Our job at Community Education Group is not to bring resources just to Community Education Group in the Appalachia region. It is to bring attention to the Appalachia region. It is to bring attention to the plight of the people of the Appalachia region. It is to reconstruct what people have in their mind, who the people of the Appalachia region are and what it is that they need. And what we have to do is that we have to do that in partnership with people who may not necessarily have a whole bunch of agreement with me on a whole host of issues. But one of the issues that we do agree on is that we've got to fix what's going on in those 423 counties. I might have a good idea on Monday. They might have a good idea on Wednesday. But we've got to have a semblance of trust between us that our primary goal is the benefit of the people, not the benefit of Tony or the benefit of CEG. And so we've been able to do that in part by figuring out, number one, what do they need? This idea of jobs is a really big one, right? We're coming from a coal economy. I can't go around bashing what coal did. I mean, coal gave people homes, jobs, educational opportunity. but a lot of it's gone now. So they say, well, you know what we're going to do is train you on computers. These people don't want computers. These people want labor jobs. So that means I got to go to Amazon. I got to go to Walmart and say, hey, can you put your bag making factory somewhere in Appalachia? Because those are jobs that resonate. Your push a button and learn how to use a computer doesn't resonate for me. So I got to understand because we've got the people, we've got to now get the appropriate job. So, I think that the other thing is that I can't look at what your politics are. I've got to look at what your heart is. And we do it all the time. And Lee laughs at me all the time. Lee's back there. When we're in meetings in some heavily red states and I show up to talk about Appalachia. We've even had one time where one congressperson got their legislative aide off the camera, literally pushed him out of the way and said, no, I'll take this. And the member sat down because I think the member was so shocked that it was me, that they wanted to have the conversation one-on-one. And I think that that's the other piece of it. It's a slow grind. It's a slow grind that you're serious. And that's a part of the culture of Appalachia. Are you from here? What do you know about here? How long are you really going to be here? Are you going to stay here? And all of those things are the things that make it work. And again, I think that we really do, to the people at SAMHSA, need a national set of criteria of what a peer recovery coach is, what a community health worker is. For our CHAMPS program, our community health workers start out at $17 an hour. It used to be $10, but now it's $17. Our coaches make $25 an hour. That's standard. We're now working with businesses in the Appalachia region to hire these folks after this grant award. Again, sustainability to get them in other jobs. But I think that until we have that national standard, people will always pay what they can afford to pay. I don't think it's that people are always necessarily just trying to get off on the cheap. But there's not a whole lot of money out there to pay these community health workers too. So if we had a national standard to measure it against, I think it then gives more validation to what it is. Instead of you, me, and you saying, oh yeah, it really works and it's a good thing. When the government says, here's your model and this is what you do, here's your best practices, this is what you do, and this is what you do across the nation, not in this town and that town, but across the country, I think you get a different outcome.
I mean, I think as long as that outcome isn't that you are forced to be in recovery and there are educational requirements, but yes. Yeah. I think another, I'll just kind of expand upon that. The workforce development program that y'all were talking about, that Us Helping Us was talking about yesterday, which is an amazing organization, an amazing program, and HIPS is also honored to be part of that workforce development program. One of the biggest challenges that we are currently facing is that all the staff who's working on that program has to pass a drug test in order to work on that program. And if we are also supposed to hire people from the community, I don't want to single HIPS out, but it means that we are having a real challenge hiring the correct people and jumping through the loopholes that we need to do. And so I think that as we are thinking about these programs, at the very least, we're looking at language, we're trying to change language, we're trying to think about the impact of the language. But we can't meet people where we're at without actually meeting people where they're at. And so that's definitely a request and a recommendation is let's try to be better about not putting up unnecessarily challenges.
Starting where people are at, excuse the preposition, requires that you understand that you hold the purse strings. And if you don't start where you are, maybe you're not willing to be there, then you have to get to this point of compromise as opposed to presuming that we all have the same intent and that it's a neutral experience. I mean, I think that is fundamentally a sticking point. Without getting into a history lesson, this country has never had a moment when there hasn't been an out group. and a disproportionate burden on some other group in favor of some other group. We don't talk about the privileged class. We talk about moving resources to a less resource group, but in this country, it's a finite fix, and moving dollars from one is seen as a bifurcated experience. For one to lose, one must win, or for one to win, one must lose. And I think fundamentally, we're playing from that page book, and that's where some of these deep-seated issues come from and the fights that ensue. Because when we talk about dollars, there are, as you point out, Lyle, there are potentially adequate dollars there. It has to be the will to move the dollars, because dollars are a tangible expression of your true value.
So my list is come to West Virginia for PACHA. Get a national standard for either peer recovery coaches, as long as it
No educational requirements and no recovery requirements.
Okay, got that part. The other thing is figure out how we're going to either engage or better engage MAT providers across the United States to make sure also that they are reporting all the data that they're supposed to report to SAMHSA, because the last time we checked, about 60% of them did not report everything that they were supposed to report. And I think that to really recognize that the syndemic in the Appalachia region is different than it is in the rest of the country. I think then lastly, I would say that the other thing, I had one more thing. I forgot, but we'll remember to email it to you.
So my list, I guess, like immediate term, I feel like my state's a little bit on fire in terms of in terms of the funding going out of there. I don't know what'll happen if it does leave. I mean, it takes away money for surveillance and for HIV testing. So even if we do realize the sorts of spikes in infection that we think could happen, we're not going to know for a long time, because we also don't have the money for surveillance or testing. So if there's any way for that money, if my state does follow through with this, if there's any way for it to move around them and go to any organization other than the state, should they decide not to have it, I think that would be critical if there's any way to advocate on behalf of that. I think the other thing is syringes. We talked about syringes, but making that, at the federal level, making that something that can be purchased with federal dollars. And I would even expand it a little bit more, especially when I was watching the presentation a few minutes ago, when we were seeing rises in overdoses that don't involve opioids as well, right? With methamphetamine, cocaine, things like that. People use those in other ways. I think people also need to have access to pipes, to safe smoking kits, because again, I think it's like it goes back to what Cindy and I have both been saying in terms of, first, there's safety, right? The syringe provides safety. The smoking kit provides safety. But second, it provides engagement. And we've got a whole group of people who, if they're not injectors, may not ever come in contact with the services that we could provide. But if we could expand those, I think we could have more contact with people. And then the last thing I think is, I love some of the efforts that HRSA and SAMHSA have been making to extend training in substance use disorder treatment, particularly around opioids. I think that's really helpful. I think those efforts need to continue even as the waiver goes away, because I think, a lot of those were designed for people to get their waiver. Now that you don't have to have the waiver, I think we still need those programs, because medical education is full, right? Everybody wants an hour for this or an hour for that. And if we don't figure out some way to make this a standard, it will drop off.
Rural health calculator, get rid of it.
Did you do your list?
I've done my list.
Okay.
Well, as someone who was a 20-some-year-old person trained in epidemiology to move to Tacoma, Washington, and get real with David Purchase, I really appreciate listening in on your conversations. I appreciate that you chose to spend your valuable time with us. There are many other things you could have done with your time, to share your lived experience in the many facets that it is, and to give us your guidance and counsel on what it is we should be focused on. Our job from here is to take that, honor you all, and the time you spent with us and the voices to whom you are representing, and move forward on these and figure out how to work sort of in our advisory capacity. You gave us a lot to think about. I appreciate the being concrete with your information. It's always helpful to us when we can have that. And we hope that as we do our work, we can maybe have individual consultations with you as we move forward. So thank you for your time and for your wisdom, and we appreciate having the opportunity just to listen in. Thank you. Thank you. So at this point, we will take our lunch break and be back here at, I forgot the time, is it like 1:15? So 1:15, back in the room for PACHA discussion and wrap up. Thank you.
Produced by the U.S. Department of Health and Human Services.